Well, good afternoon, everyone. And as my co-panelists get settled today, I'll introduce myself, Chantal Worzala, Vice President of Strategy and Engagement at Sequoia Project. I am so thrilled to be back to moderate our Government Affairs Roundtable. We are so fortunate this year because we have tremendous experience in the regulatory and legislative arenas here on stage today. I'm going to give you their formal titles and introductions, but I asked them each to also share with you what it is about their previous experiences that has shaped their views on interoperability. So I'm going to start with Alex Mugge. Alex, give a wave. She's Senior Director of Global Health Policy and Regulatory Intelligence at Oracle Health. But she also worked at CMS for 15 years, and her final role was Chief Health Information Officer. She also, since the news is all about the Oracle QHIN today, she will also serve as the Executive Director for the Oracle QHIN Governance Committee. So welcome, Alex. We have Brett Meeks, who is a Nashville native now. We'll call you a native. Vice President of Government Affairs for Health Technology and AI at Jeffrey J. Kimbell and Associates. In that role, Brett is navigating and advising organizations in policy and law at the intersection of healthcare, data, and technology. He served in the U.S. Senate for over 8 years, including as Deputy Health Policy Director for the Senate Help Committee. And it was at that time when he led work on the health IT provisions in the 21st Century Cures Act. And then, of course, Lindsay Austin is no stranger to this crowd. Lindsay is principal at Troutman Strategies and is a key resource for the Sequoia Project on government affairs and federal relations. So Alex, I'm going to start with you. We have this theme on the panel of working in government and working outside government, and I'm interested to learn a little bit more about how your government experience shapes your views on interoperability.
Yeah, thank you, Chantal, for that. I do want to just highlight again, that Oracle has turned it up to 11. We are the 11th QHIN to join TEFCA, and that is, I will say, very exciting for this organization, and it's very interesting to me personally, having come from 15 years in the government where I was there for the passage of the 21st Century Cures Act. I was there when when TEFCA was starting up and was first. I think we started with the TEF part, and then the CA came later. And so throughout that process, and then I remember the day that Mickey Tripathi called me to tell me who the original 6 QHINs were going to be. And then I was there still with the government through 10, and it's great to now be on the other side with number 11. So just a really important day for us and for our interoperability journey. But you asked about my experience in the federal government and how that shapes coming out. And it's interesting because you guys have all mentioned many of the rules that I worked on at CMS. There was the original 9115, interoperability and patient access, the infamous 9123, which shall not be named, the 0057, which has come up a lot today, interoperability and prior authorization, and the upcoming 0062, which is interoperability and drug prior authorization, and that will be very exciting when that one comes out. So, but having worked on all of those rules and really thought about how those rules could help shape interoperability and could bring payers into the interoperability space, it was a really exciting time to be part of all of that. And now on the other side, the implementation side, it's interesting to see how we implement these policies and what some of the challenges are. And I think we'll probably talk about that more as the panel goes on. So I'll stop there.
Great, thank you. And Brett, how about you? You've had a little more time out of government, but how did the worlds come together for you?
Well, serving in government was probably one of the most important things I've ever done, and I look back at certain times when you're very stressed, but I realized that was going to be the coolest job I've ever had. You realize that later, the team you're working on, and unless you've really done it, they call it federal service or government service, and you kind of like, oh, these bureaucrats or whatever, when you haven't done it. But when you've done it, you realize just how thankless it is, how little you make, how much you work, and how much everyone that does it is just really well-intended. I would say, especially on this topic, I always say interop is very bipartisan. People work together. The three of us, actually the four of us, we're all together working on this stuff, on phone calls back at the inception of all of it. So I think now, having gone to the dark side and private sector for a long time, there's two things. One, it's like government is well-intended and they want the right thing. And so realizing that and trying to help them get it right, because they want to get it right and you want to get it right too. The other side of it is you have to be careful what you ask for from the private sector, because you might get it. And when you're drafting things or passing legislation or laws or writing regs, you have to be careful how you craft them and how it could be interpreted. So there are things that, I am guilty of that are in federal law now, and I'm now serving penance as a consultant, helping clients comply with it, which is pretty gross when you think about it. Like, I didn't do this stuff because I wanted to charge someone a retainer later. But I also, you feel this sort of duty to fix things that you either got wrong, or if you didn't draft it right, someone implemented a way you didn't think was going to happen and you want to correct it. So I would just say that it's very interesting to have seen both sides, and I feel very thankful to having done it. And it's a different perspective on, how to achieve this common goal I think everyone here wants to achieve. And it takes, it does take a very delicate partnership between public and private sector, and I think Sequoia is a great example of that.
That's fantastic. And Lindsay, before I turn it to you, Brett kind of reminded me while we were doing a pre-conversation that when I led digital health policy at the American Hospital Association, I was working very closely with him when he was on the Hill.
I thought she was a CMS staffer. No offense, but yeah.
And of course, I worked a ton with CMS folks when I was at the AHA. So, Lindsay, you are right at that nexus of public and private and supporting the Sequoia project in our work at that nexus.
And thank you. I'm so glad to have these two. I handpicked them. We wanted them here for that exact reason, so you can understand how awesome it is to have this knowledge base, to be able to reflect on where we are now. I happen to specialize now 16 years in government relations and representation of organizations where they're wanting to meet with Washington, explain their story, tell their message, but I actually do go back further, 20 years, when I started out as a baby Capitol Hill staffer answering phones for a congressman, my hometown congressman. I was actually on the Hill when high tech was passed, and I can remember my father's as a physician and not really ready to transition to electronic health records, but knew that it needed to happen. But at the time, the economy just completely crashed, and we were looking for something to help support moving towards the next generation. And so you've got high tech. It sort of slid under the radar, not too dissimilar from the interoperability and health IT portions of 21st Century Cures. This massive bill, but in there, and it included some really significant reforms and basically the Kickstarter for where we are now. So I got to work on that. I actually managed the small business committee, so small businesses were affected because they were given this opportunity to utilize the funds to kickstart their efforts to have interoperability. And if you asked a member of Congress, especially my member of Congress, to even pronounce the word interoperability 18 years ago, that was actually a pretty big deal because they did not understand it. Meaningful use, it was, I'm sure, as government folks, So anyways, I do want to make sure you understand there's all sorts of flavors of people who work in government, but you always have that itch once you leave to come back and say, gosh, this is what I would have done. And I totally reflect on my 6 years on the Hill as being so significant, even though I might have been making coffee, answering phones in the early years. You really can't forget that time. And you want to go back within, you remember some of the dark days too. Yeah. So anywho, I hope that gives you a little perspective. I think we bring a lot of different backgrounds, and Chantal working with you over when you were at AHA. So I think we should go ahead and get started.
I think we should.
Yep, I'd love to go and kick off. We like like to do a little table setting exercise here, and we're going to get through it pretty quickly. Have a couple of slides. I just, you guys, just a few things happened or didn't happen for like 45 days, so we want to talk through it a little bit, and I'll have this like therapy session about really, we're going to go back to government. Let's not let government shutdowns happen again. I don't know, what a concept. So I'll give you a quick agenda, and I'll get through it quickly because I think the question and answer section of this is going to be really interesting with our panelists today. But we're going to talk through a little congressional activity review, what happened with the shutdown, what didn't happen with the shutdown, where are we now, what was really holding it up with the ACA vote. Speaking of ACA, health IT policy, and agency activity, and of course we'll get straight into the question and answer. So again, level setting here. How do we even get in this mess? Well, Congress has tight margins, and there's no supermajority to get every single thing done. Although they were able to get some pretty big legislation done this year, considering the One Big Beautiful Bill Act that is now in law. And so there are ways to do it. Reconciliation was one. We'll talk a little bit about that in a second too for reconciliation part 2. But you see that we have very slim majorities in effect, and they have been this way for the last 2 or 3 Congresses, with 219 Republicans to 214 Democrats, and then it'll be split with these 2 vacancies that are coming up. The Senate, which really highlighted its challenges with getting its votes across the finish line for this recent government shutdown debacle, we have 53 Republicans, and you need 60 votes to get traditional legislation across the finish line that don't require reconciliation or some other more simple majority procedure to get a bill done. 45 Democrats and 2 independents that caucus with Democrats. So that gives you perspective. It's that we went into this Congress knowing we have these challenges, and I don't foresee there being a super majority the way there was back in 2011, and I think there was another big spike, but you're going to see the trend of continued tight majorities each election. Okay, so how do we end this recent terrible shutdown? The longest one, I think they wanted the longest one on purpose, which still looking back, we're all gonna say that was not the right move. But on November 12th, they were able to get the government funded again. And by government funded, that's the continuing resolution for the majority of government. And a couple of bills were actually pushed forward with the FY26, so new levels of funding for a full year. So several agencies will be funded regardless of what happens at this new deadline. So how do we get there? Well, several Senate Democrats, 8 Senate Democrats finally came to the table. I will not rehash the 45 days, but I'll tell you that it was going to happen inevitably, no matter what people are saying. Democrats were coming to the table to get the government funded, and here are the ones that ended up doing it. Some are retiring, and some are not up for re-election in 26, so they have their political reasons why, but also they just were tired of it, and everybody hated it, and they kind of needed to be the scapegoats in a way to get it done. But it's not over. It's going to potentially happen again in January. So we are into the continuing resolution, January 30th, but like I said, there were a couple bills that were able to get passed at the new levels, so that's what they're looking to do now. We'll talk about that in a second. But part of the legislation that was passed on November 12th to fund the government removed some reductions in force. I think that's very interesting for this audience, and knowing that a lot of those jobs that you thought may have been just removed by the existing administration, that was reversed in the legislation. So there were also some health extenders, which we see almost every year at the end of the year. I don't know, you guys have all been to these conferences, and I constantly think I'm talking about shutdowns every single time. Like, it's the timing in November. It's either before, after, or during the shutdown. I am grateful that our government officials were able to join us, so that is definitely a plus for being after the shutdown. So some of the health extenders were included, but they're going to be up again January 30th when we're looking at rehashing all of this. But there will without a doubt not be a full government shutdown. There could be partial, which we have seen in the past, which held the longest shutdown previously before this one. So what's causing the fight? Well, it's these ACA enhanced premium tax credits that were included during COVID, the COVID legislation. And so Democrats decided this was going to be their mantra going into the shutdown. And right now, Leader Thune he promised to vote in December, but it's really not the top of the pile right now. I think they're looking to get past this holiday, and technically December 31st is the deadline for these subsidies to be increased. So I think you guys have probably heard a lot about this. There's still going to be a lot of debate. The president does want to get engaged on this. I think he's finally heard that affordability of healthcare really matters, and he didn't really want to get his nose in this shutdown piece, but he is going to be involved in making sure he's communicating with his conference and his members about getting some kind of healthcare package together, and hopefully that will include something that will satisfy the Democrats in order to not have a stalemate or a potential another shutdown in January. So they do have to get Republican support for this. We'll have to see how that goes. There's going to be some moderates that want to get reelected, and they have people back in their districts that are going to see their premium spike starting December 31st into the new year, which is going to be really hard considering all the other affordability challenges that are happening. We're also discussing right now, the Senate and the House are trying to figure out, well, what would our health care package look like? What would we do to basically find a good compromise? We don't want to just give the Democrats everything that they're asking for. Republicans need something too. And so there have been suggestions by Chairman Cassidy of the Health Committee to provide for HSA spending dollars, giving government the ability to put in funding for HSAs. So that's been a very popular Republican mantra and something that's been brought up in previous health care bills. So you could see that on the table, and we could rehash a couple of other issues that always make debating a health care package really fun and goes by really quickly. No, it'll be painful. Okay, what other activities going on? So all on top of the shutdown, again, appropriations, here's a couple of bills that they're looking to maybe pass before Christmas. Defense and Labor H, the bill that funds HHS and all the agencies that you guys get to work with on a regular basis. I'm thinking that's going to be closer to the Christmas holiday. We may be able to get something early December on transportation, interior, commerce, justice, science. That still leaves a handful of bills or a handful of agencies unfunded. They, on the day of the shutdown, stopping the shutdown, they did hotline a handful of bills. So they're ready. Appropriators are ready to go. These folks they like to get their work done. So keep your eye on appropriations. And then with AI, I think AI has been the topic that just the undercurrent it's always going to be there. There have been a couple of hearings on privacy and AI. There's a HELP hearing in October, and then there was one in energy and commerce in September. We'll talk a little bit about that, so I won't drone on too much, but you're always going to hear AI, so just get used to it. Data and privacy, I think this is really important. Chairman Cassidy just released his privacy draft. If you haven't gotten your comments in, get them in soon, probably this week or next week, but they really want to hear from everybody about how that's going to look, and it really will inform potential AI policy going forward. Chairman Guthrie on the House side is also looking to do something end of year. We'll see if that interferes with what they're trying to do for the final ACA-related work. And so healthcare package, I think we're kind of combining these things now. We just have to see what plays out this week. Next week will be the Thanksgiving holiday, so they will not be there debating these policies. They'll be gone by Friday, so thank goodness. So again, PBM reforms have always been in the mix too, so keep an eye on that as being one of the pieces of a potential healthcare package. And as of today, it's the only thing I had to update, day of presentation. The Finance Committee actually moved forward with their OIG nominee, Thomas Bell, and they pushed him out of the Finance Committee, so he'll have to get a vote on the Senate floor, probably in some kind of en bloc amendment or something along with other nominees. The Surgeon General nominee had her hearing, but she actually gave birth that day, so she missed her hearing. So she will be going back again, I'm sure, after she's off of leave. And then I think something else to point out with the One Big Beautiful Bill, this is huge, it's been discussed today, but the Rural Health Transformation Program, I think is going to be a resounding topic for not only administration, but for members of Congress who promoted this legislation to get back into the states to really help promote getting technology advanced in these rural areas. They've designed it with formulas to make sure that the most vulnerable states are going to have access, but big question marks on that. We might get a chance to discuss it going forward. I don't necessarily need to recap all that's going on because we had some great speakers earlier this morning, and you've heard a lot about what's going on from the agency perspective, and of course, Alex can shed light on some of this, but the health tech ecosystem being led by CMS is truly innovative and exciting and fun to watch, especially alongside of some of the more historical work we've been doing around interoperability with TEFCA rollout and all the other pieces that are coming together on information blocking. Prior auth led by CMS, I think, is a big deal. I think that's really a priority for the administration. It is something the president and the secretary pay attention to. They know that it works. They know that it makes the payers sit up. And so I think it's something to keep an eye on. HIPAA modernization being led by CMS and the Office for Civil Rights. Deregulation, basically the agenda of deregulating across not just HHS, but all of the administration's agencies. This is something they're looking at. So as long as this administration is in effect, they're going to be looking to find ways to deregulate, cut red tape. Information blocking enforcement, big deal, being led by ASTP, ONC, and OIG. I think that's going to be something to keep an eye on, and I do think will be continue to be prioritized. And elevating ASTP's input on a lot of the work that's coming out of 21st century cures and everything that came from the regulations there. So, and then MAHA. The MAHA movement is taking over Washington. They just had massive events last week, so I think that they're really taking that forward and utilizing this wave that Secretary Kennedy insists on making sure it's every single day he's thinking about how to promote MAHA. And even if that means through health tech ecosystem and other ways, I think that the mantra was making health tech great. ... again. I don't know if you can, it's like making health tech great again. Making health tech great, I think, fits into the mantra. So, but yeah, so that was a quick, really fast run through because let's go on and get to questions. I know Chantal's tapping me ready, time for Q&A. But yeah, so I'll hand it back over to Chantal to dive in and let our panelists, comment on either some of these topics or whatever we think might be of interest to the audience.
Great, thank you, Lindsay. And I just want to share, we rely so much on you. Thank you
It's a lot of pressure.
for helping us keep track of what's going on and also how we can bring our best game forward in terms of really sharing how it works in the real world and working with the federal government to make things work better in the real world. And I'm going to skip ahead a little bit just to warn my panelists. But Brett, I wanted to start with you because you kind of foreshadowed this question in your opening remarks. So when you look back at the 21st Century Cures Act, what's worked as intended and maybe what hasn't aged quite as well?
It's great. What are you talking about? So, if you look at it's very interesting that we're sort of all up here together. Because we wrote the statute, me and lots of other people, and it was voted on by Congress, and then Alex and lots of other people implemented it, right? And it's still being implemented. This passed in 2016. The rules started coming out in 18 and 19. So it took a long time, and I think a lot of the issues we were trying to fix back then are still issues today, That's why I think Amy Gleason, I don't want to steal from her, but she says make health tech great for the first time, right?
Exactly.
Yeah.
Exactly.
So I think, information blocking to me was one of the biggest things we worked on. And, we sort of, put the number in there last minute, like the night before we dropped the language, because we were like, what are these CMPs going to be? What is it going to do? We talked about it, but we're like, well, we'll just deal with that later. And then it's like 9 p.m. and we're like, oh God, we got to decide this, And I don't know, because we haven't seen that enforced yet. And so what that looks like. And I will say the goal, bipartisanly too, the Democrats, we worked very closely together on this, was that it would never have to be enforced, that it would just enforce or incentivize behavior, right? I think it probably will be enforced and it'll probably be litigated. So I think it's one of those, like, we'll see how it ages, with a lot of this stuff. I think there's still some provisions in there that have not been implemented. We talk about the flow of health information and who can access and patient access and things. And there's language in there that individuals, the individual right of access is very important, and I would say that's bipartisan too. Trump 1 was very interested in it. The Biden administration was interested in it. They have different flavors, but it's like, this is consistent. Everyone wants this. And we codified it. It's a rule, but we put it in the statute that a patient has a right of access because we believed in it. But we also put that you could access from a business associate directly as an individual. And that hasn't really been implemented. It's in the statute that you can request anybody that's got your health information. It's yours. You should get it. But right now it's sort of controlled by different entities. So I would say that's still, and there are like 6 other examples of things that just haven't been acted on. So I did a variation of your question because I think it's all wonderful, right? I think it's going to be interesting to see how it plays out. Like, it was very high aspirations, trying to solve complicated problems. I didn't delete like a whole section title, so there's an inappropriate title in there that's in the code, so that's probably aged really poorly. Legally, you're supposed to ignore that kind of stuff. The titles don't control, but they're like, well, it says this is in here, but it's not, and like, so that's probably aged the poorest. You can find that on your own.
Homework assignment.
Yeah.
Alex, Brett said it himself. Congress writes the rules, CMS implements.
This is true. Well, there are the laws and the rules, and then there's also implementation on the private side. So
Yeah.
it sort of continues, right? And then we get the feedback from the private side, and then we start the cycle over again. But yeah, it's CMS. I would say what was really interesting when the 21st Century Cures Act passed was, I remember having a call with our attorneys, like, maybe a month after. So they'd had some time to think about it, and we were talking through, like, well, what does this actually mean, and how do we apply this, or how do we, like, where do we need to write a rule, and really, is this ONC's authority, or is it CMS's, and like, how do we work together? And the attorneys, you know, in a couple of instances were just like, we don't know. Like, it was just so much to think about that was different than meaningful use in, like, when we had high tech, it was like, you know, go build this program and do this thing and spend $36 billion. And in 21st Century Cures, it was more like, this is a big concept, we need to address this, and there are a lot of ways to go about it. What was very clear is that, you know, it established TEFCA, and really talked about information exchange, and so that's a lot of where we put our focus over the years. But you know, what wasn't, I think, addressed in, or what hasn't really been addressed in any laws is the greater interoperability. I guess it is basically talked about in 21st Century Cures, but the greater interoperability ecosystem. So back when I started at CMS, I think interoperability was all about EHRs connecting. And I think that's the way that traditionally a lot of us think about interoperability, is just physicians, clinician offices, like just being able to exchange data. But it's so much bigger than that, because healthcare has so much rich data, and payers have a ton of it. But they were never impacted by interoperability until we started writing these rules and saying, you guys have to contribute that data too. And so I just think that, you know, having worked at CMS when we expanded that to include payers and to include data outside of the EHR, I think that's where we're starting to get to this ecosystem that you're all in this room to build, right? Like, we're all here working towards true interoperability in those longitudinal health records that we talk about, but that requires the data from all players in healthcare. And you know, I don't want to go down the AI rabbit hole just yet, but for AI to function well and provide valuable insights in healthcare, it has to have access to all of that data. So I think it's really, it's been really critically important to start unleashing that data and making it available to create those patient records, create insights, and to be able to apply AI and start actually learning more from the data that we have, getting information out of the data that we have.
So I'll just reflect on this a little bit as an observer, and thinking that, you know, 21st Century Cures Act actually created interoperability in government, because it made CMS and ONC have to work together incredibly closely. It has pointed out the role of OCR as the arbiter of privacy and patient access. So now that agency, you know, we keep pulling on OCR to say, come on, help us figure some of this out. They still refuse. They give the guidance they give, and then they stop. But they're a player as well. And now with information blocking enforcement, we have OIG. So cross HHS interoperability is also a function of 21st Century Cures, as well as the actual digital health information interoperability that everyone in this room is working on.
And the agencies that will ultimately potentially utilize QHIN network activity.
Yes,
So
indeed. SSA, VA,
IHS.
DOD, IHS. Yeah, we're creating interoperability across both federal and private sector landscapes, which is kind of exciting. We have about 16 minutes left, and I am going to leave 10 minutes for Q&A. So I want y'all to put on your thinking caps. You have this amazing panel to ask questions. Not yet.
Always first.
But in the 6 minutes we have left as a panel, a couple of things I want to ask. I'm going to jump right into AI because I think AI is on the periphery of all of our conversations. So what is the role that AI-driven tools are going to play as we look ahead? How is AI going to fit into the regulatory and compliance landscape for health data? And Alex, I'm going to start with you on this one.
Okay. So there were a lot of committees on AI when I was at CMS. I think too many work groups and committees talking about AI, and I don't know that we firmly landed on any particular answers of like, yes, this is how we're going to do this or not do that in terms of like how to regulate AI. So no firm answers, but I think I look at this question more so like the impact that AI is going to have and just how the rulemaking and implementation cycle works. I mean, I'll speak to the CMS interoperability rules since those are my babies, my children. They're still at CMS. Those interoperability rules require the use of certain standards, and they strongly recommend the use of implementation guides that many of you in this room have worked on and are familiar with. And I think that the question I have around now seeing AI out in healthcare and just in our phones and everywhere else is how is that going to change the way that we regulate technology? Because in some ways, will that AI replace the need to be so specific in implementation guides, or will we need to be more specific about how we implement the AI to make this interoperability work? I think there's a lot of opportunity there. I don't have all the answers. I mean, Oracle is using AI for a lot of really exciting things, but people are taking different approaches, right? And everyone can sort of use AI in the way that works best for them. But then when it comes to regulating that or putting it in policy or laws, at some point, what does that really look like? How will it change the way that we review old technology? We've got a lot of standards written into laws and in rules that don't always get revisited. And now maybe is the time to start looking at that and start thinking, where can AI replace, supplement, or should it not touch some of those standards? And that's a really big question. More next year.
And how about you, Brett? What do you think about AI and
I think it's
legal landscape?
The most interesting and exciting thing happening right now, generally, right? And no one really has answers because we didn't know where all it's going to go. If you look at the news the last couple of weeks, like, are we building too many data centers too fast? Are they going to actually build data centers in space? And all this crazy stuff that sounds like it's in a movie, right? And all the AI apps in my phone are actually in a folder called Skynet. So I try to reference the Terminator as many times a day as I can. So anyway, sorry for that. But I think it's really creating efficiencies. In your day-to-day life, Gemini has improved Google search, but there was a while where Google search was not great. So I started using Perplexity. If you guys haven't tried it, it's great. It just makes things more efficient. And you need to cross-reference and cite to make sure it's actually true, because it will infer things. And you guys know this better than I do. But I think just figuring out what that means for healthcare. So does that improve research? Does it improve workflows? And all those things that are more on the administrative side that I think are really, really helpful and have great potential. We have documented provider shortages across the country, particularly in mental health, that did not benefit from meaningful use in the incentive payments for EHRs. So is there the potential for maybe this rural fund, for example, to help those types of communities adopt these tools? And then we have tools that make things more efficient, and we have better access and things like that to sort of answer these unanswerable or entrenched problems in healthcare. And now where government comes in, and I know we still have some government folks in the room, so sorry, not sorry, but government doesn't do technology very well. We try. And in healthcare, there are different examples of that. And I think there's just so much unknown about AI that we have to be very cautious how you regulate it. The president, I think, was tweeting last night that we can't have the states, or truthing, whatever it's called, the states having this patchwork of different laws. And it's very interesting right now the way AI is regulated through different sectors. The transportation department controls the Waymos, right? And those things. And in healthcare, it's HHS, it's FDA, ASTPO&C has a role too, and it's in an EHR. And all this is still being sorted out. I think the biggest question is if you look at some of those clinical decision support tools or software as a medical device guidance that FDA has put out, and how they're treating AI devices as if they're a medical device. And that statute was written in 1974, There was also a court case earlier this year where FDA got a rule reversed by the courts because they were stretching the device authority too far. So I think the agency is trying to be very cautious, like, okay, are we running afoul of the courts with trying to regulate these things under this old authority or not? There's different opinions on this, but it's really sort of a new field right now, how this is gonna work out. How do we take an authority that's meant to approve something like a pacemaker that is fixed in time, and use that same authority for something that is constantly changing and learning, and they're struggling because we all are. We're trying to understand these tools, but we're trying to balance the great promise of these tools, I think, with some of the Skynet fears, put those over there, but also are we going to make sure that things are safe and effective, medically necessary, that we're paying for, and all that stuff? And we're working it out. It's a fun time to be alive.
Now you're lying, Brett.
What about
I'll
what?
be back.
Huh?
I'll be back.
Oh yeah, nice,
Next year to talk about it.
nice.
I'll add one quick thing on AI
One
too,
quick thing.
just real quick. I think full circle on former government workers here, representing members of Congress, committees, and the federal agencies. Really what has to happen is that real world information. It's okay to go in and tell your stories from your organizational perspectives. That's what government needs to know. That doesn't mean they're gonna take it and draft new regulations. That means they're just gonna better understand it. This administration is notorious for being wide open about wanting to hear from stakeholder communities, wanting to hear from industry, wanting to hear from nonprofits. So I think that would be the thing that I would continue to reinforce with Congress, with your representatives, with the agency officials, the career officials, the political ones. They want to hear from you and what's actually happening so they can apply it to whatever decisions they do make. And not just because they're going to create new AI rules, but they're going to apply it to rural health transformation. They might apply it to TEFCA. They might apply it to the health tech data ecosystem. So there's just so many ways that your input can enhance and make this a better process for government. At the state level too, so.
Well, it is your turn, audience participation. Welcome you all to ask your questions. And as Matt gets the mic, I'm just going to reflect on AI that it is liability that will be the big question. Who's liable when something bad happens?
You mean like the user or the developer?
All right, let's hear the question.
Okay, Matt Eisenberg, Stanford Healthcare. This was fantastic. I'm clearly very excited. I love this stuff. I'm really geeking out over here. Thank you. I suggest next year you come back for a 2-hour panel, just 2 hours. I have 4,000 questions. I'm going to give you 2. First is looking back. The first question is, whose bright idea was it to define interoperability in law and access, exchange, and use? Who came up with that one? That's the past one. And then looking forward, and maybe this is for Lindsay, is it seems like there's some agreement about extending the telehealth flexibilities that we learned during the pandemic within Congress, even though it's a split Congress. How come it's taking so long to move that forward? Those are my 2 questions. Thank you.
First one yours.
Brett, I think you might have the first question.
Cures started in the House. We picked it up in the Senate. Interoperability had already been in statute in MIPS. So the merit-based incentive payment system that I think everyone hates now, but at the time was the golden poster child that was going to save us from SGR. And so then we were looking in Cures at basically $38 billion in incentive payments had gone out, but the systems weren't talking to each other. So there's this public health issue where the information wasn't flowing, but it was federal investment. So that's where all of it came from, and we felt like we had to define it. Access, exchange, and use, I know I had a hand in it. I don't think I was alone. We were just trying to figure out how to cover data, and as a patient, as a healthcare provider, a plan, a caregiver, anyone in the care continuum, what are the main ways you can define the data, how you're going to get it, how you're going to use it. So that's, I try to say access, exchange, and use, like in all white papers and things now, because it's not just getting it. I'm sorry, I know a couple of years ago, I had a medical procedure, and I was like 4 hours post-op, and I was laid up, recovering, and I pulled up the record, and it was already there. And I pulled up the surgical notes and started reading them. And it was like one of those moments, like, I did it, And I was like, I've actually done something in my life. This is great. I have no idea how I'm going to explain this to my mom, but I'm so excited. But it was basically view only. I couldn't send it. I couldn't screenshot it or anything. And I'm like, okay, baby steps. So we're still getting there. Sorry.
Love that. Good for you. He did his best. There's a lot of people working on it, and it's also collaborative. It wasn't Brett's decision. It wasn't any one member's decision. It was four corners. It's Democrats, Republicans, the White House. So you did the best with what you had, and you moved it much more quickly than some, even implementations move. So,
Yeah.
Quickly on telehealth, I'll actually say when the shutdown was emerging, I was like, telehealth's going to get them. Yeah, telehealth's going to make them come and realize, our seniors aren't going to be able to access their doctors while they're sitting in rural America expecting to be able to see their clinician and have these discussions. No, I was wrong. That did not. It was, they didn't care. Everything was out the window. But I feel like telehealth is one of those mainstays, and that's one that always continues to get reauthorized. Whether they need to maybe improve it or modernize it, that's probably the next phase of this. It's going to look something like what's happening with AI and privacy and all that. So I think we'll see it. Usually I think telehealth likes to maintain a neutrality across policymaking, and members of Congress love it. So if you keep coddling it, keep talking about it in great ways, and talk about the performance of the telehealth and extenders, they have a great trade association in Washington. So yeah, I think that there's hope for that. Maybe not all other items of the healthcare package emerging. So.
All right, next question.
Hi, Raj Tokchichu, Centaur Health Solutions. So when the internet first came, nobody really cared for it, and now everyone wants to use every communication through internet and interoperability, and we are talking about it now after so many years. So the AI piece, the private sector is already enforcing rules that their employees must use AI to do their work, and in the government on the opposite side, how can we regulate, how can we stop people using AI, how can we say AI can be used only in this way or that way? So is there anything on the other side in the government saying we should say for these standards or interoperability pieces, you must use AI? Is there any policy promoting or towards that direction?
So when I was still at CMS, so I only left CMS like 4 or 5 months ago, but over the last couple of years.
Still recovering, right?
Still recovering. Recovering semester. I'm quite serious when I say that there were a lot of work groups stood up to look at AI and look at it from like, how do we regulate it? How do we use it? Where do we really not want it? And I think that, and Brett, I think you alluded to this a minute ago too, I think there's more of a desire to just say, okay, we don't have the answers, we need to take a step back from this and not regulate it yet. But there are some places I think that we can easily say this is where we don't want to use it. I think your question was, are there places where we say we definitely want to use it? And I don't think that we're quite there yet, but other opinions?
I'm working with building a coalition, a trade association around advising small businesses on how they do their investments and utilizing AI, and we're doing exactly that. We're telling government, like, maybe AI doesn't need to be this, or maybe you don't need to apply the same AI standards for the larger investing companies versus the smaller investors. So the discussion is what's happening. So yes. I think there's going to be a space for conversation around, can we just do this the good old-fashioned way, but also not apply every single rule to every single entity that might be utilizing AI? And I don't use my company's AI. Is anyone from Troutman in here? No. I use ChatGPT.
Yeah, I think I'll just add from the Sequoia project perspective, because we've had our own conversations about where does AI fit in our interoperability work, and I think there are two things. One is you need good quality data in order to use your AI tools. Yes. But then we can also think about how AI tools can help us get good data, right? Because the AI tools, as Alex was pointing out, can AI take the place of having to code data to certain standards, or can AI help you map your data to those standards? So I think there's a lot of really interesting work to be done to think about how it is that we can deploy these amazing tools to get clean data and share it. And maybe AI helps with deduplication, maybe AI helps with patient identity. I would love to hear about research into that. So we have 0 seconds left. I want to thank my panel and leave you all with the interesting question about how would you use AI to further interoperability? And we'll talk about that next year. So thank you all for your time and attention.